Right, welcome everybody to the second BFIRST and BSSH Trainees Global Journal Club. It's really great to have you all here. This is going to be hosted by the BSSH this time, and we've got an excellent consultant faculty in the form of Mr. Wee Lam, consultant plastic surgeon in Edinburgh and current editor-in-chief of the Journal of Hand Surgery European volume. And alongside that, we've also got Mr. Jonathan Jones, consultant hand and wrist surgeon in Peterborough and honorary clinical lecturer at the University of Cambridge. So it's great to have you all here. I'm just going to see how many people we've got in the room. So we've got 3 attendees. We'll give people a bit of time to join in. We know it's a busy time of day with people, so we'll give everybody a chance to join in, and then we'll make a start. We hope you've all had a chance to read the paper, which is on a really common injury in our orthopedic practice. It may be less common to the plastic surgeons in the audience, but certainly something that you'll see a lot of if you are doing any global outreach work. So I hope it'll be useful to everybody. If people could place their country that you're from in the chat, would be really helpful for us to get an idea of who we've got in the room, please. And just some general housekeeping, so do use the chat throughout the evening and ask questions as we go along. And feel free to interrupt us, and no question is too simple. And please use the Q&A for any questions. So use the chat for any general comments, and please use the Q&A for questions. So we have 3 attendees so far. We've got Leo, Marwa, and Rai. Thank you so much for joining us this evening. Hope you will have some more join in as well.
Yeah, good evening, everybody.
Apologies, Leo. It says the chat is disabled for you. I'm not sure why that is. I'll try and look into that. Just give me one moment. Do you just place any comments in chat then in the Q&A, and we'll be able to see it. So thank you for raising that. I'll give individuals a couple of minutes to come in. Great. Welcome to those who are joining us now. It's really great to have you here with us this evening. We look forward to an evening of healthy academic discussion.
Hi, Kieran. Are you there?
Hi, Kieran. Thank you so much for joining us. It's wonderful to have the author of the paper joining us this evening. So a really fantastic opportunity to ask him some questions directly. I think we'll make a start, as we want to be respectful of everybody's evenings. So welcome to the second BFIRST and BSSH Trainees Global Journal Club. This is going to be hosted by the BSSH Global Partnerships Trainee Committee, alongside our consultant colleagues, so Mr. Wee Lam, consultant plastic surgeon in Edinburgh and current editor-in-chief of the Journal of Hand Surgery, European volume, and Mr. Jonathan Jones, consultant hand and wrist surgeon in Peterborough and honorary clinical lecturer at the University of Cambridge. My name's Roa, and I'm honoured to present tonight. I've just handed over as chair of the Global Partnerships Training Committee to my colleague Haneen, who I hope will be joining us later. So the aim of this journal club is really to provide a global platform for us to discuss papers and that are relevant to an audience in reconstructive hand surgery, but also that are relevant to a more global audience. And we hope that by doing this, we're improving research education in reconstructive and hand surgery, and hopefully building a community of trainees who are interested in global hand surgery and reconstructive surgery. And this is really a partnership and a joint collaboration between the BFIRST Trainees Committee, of whom we've got two of their members here with us today, and ourselves from the BSSH Global Partnership Trainees Committee as well. I'll allow BFIRST to introduce themselves.
So good evening, everyone. My name's Alva. I'm one of the BFIRST Trainee Committee members. I run the events for our committee, and I'm a plastic surgery trainee. To speak very briefly about BFIRST trainees, we're a community of medical students and doctors who care deeply about global access to safe and affordable reconstructive surgery. Our aims are to act as a UK-based forum to share resources like this journal club this evening, and promote responsible trainee involvement in overseas activity.
Thank you very much for that, Alvin. So the overall aim of the Overseas Committee is to use BSSH resources to deliver maximum possible benefit to patients in need of hand surgery in economically challenged countries. And we work alongside the main committee to coordinate the involvement of trainees in global hand surgery. So we help to develop and disseminate educational content and help to really develop and deliver sustainable educational and surgical projects in low resource settings. And it's we're really honoured to have Mr. Wee Lam with us tonight. He's an academic consultant plastic hand surgeon. He's the immediate past chair of the BFIRST, and most of his clinical practice was undertaken at the Royal Hospital for Sick Children in Edinburgh and St John's Hospital in Livingston, also up in Edinburgh as well. And his special interest and academic research focuses on congenital hand anomalies, developmental biology, and the use of patient-reported outcome measures in paediatrics and the assessment of congenital anomalies. He's currently editor-in-chief of the Journal of Hand Surgery, has many publications, and is honorary clinical senior lecturer at the University of Edinburgh. So welcome to you, Wee. And alongside Wee, we've got Mr. Jonathan Jones, who's a consultant orthopaedic surgeon and formerly a medical officer in the Royal Air Force. And he is the immediate past chair of the BSSH Global Partnerships Committee. His clinical practice is undertaken in Peterborough and Stamford Hospitals NHS Trust in the middle of England, and his special interests are in complex hand and wrist surgery and global surgery, and he's led many surgical projects in countries across the low resource setting. And he's also an honorary clinical lecturer at Cambridge University Medical School. So welcome to you, Jonathan. For those that haven't joined us before, so our journal club is inclusive. It's open to all trainees and individuals with any interest in global hand and reconstructive surgery. We discuss diverse literature. So if you have a suggestion of a paper that you'd like us to look at in future journal clubs, please do get in touch with any of us, and I'll share our contact details at the end. And this will run every 2 months, and the recordings will be available on the BSSH YouTube and BFIRST website. So for tonight, I'll go over a 5-point summary of the paper, as well as a section-by-section analysis, following which I'll pause so that we can ask questions as we go along. And do feel free to share your overall thoughts and discussions at any time throughout the evening. So why select this paper? Well, this is a really common injury, both in low and high resource settings. It's a very recent paper, only published in 2021. And I think outcome assessment is really key to informing our practice and assessing the outcomes that you get from your standard practice is really key to seeing how you can improve the care that you deliver and drive healthcare reform. So in terms of a 5-point summary, well, this is a retrospective study assessing non-operatively treated pediatric supracondylar fractures in a resource-limited setting. Their aim was to assess clinical and functional outcomes of non-operatively treated supracondylar humeral fractures. And they looked at all fractures treated at a district hospital in Malawi between January 2014 and December 2016. 182 children were treated during that time, of whom 75 were available for follow-up. And essentially, although they had good functional and cosmetic outcomes, Gartland's type 2 and type 3 fractures were much more likely to suffer a complication. And their summary was that these injuries are a high risk of clinical complications or functional impairments. And this really highlights the need to increase surgical capacity in these low-income countries. So let's take a closer look at this paper. We'll follow the standard format, and I'll pause after each one, again, for any questions or comments. So in terms of the PICO, so did this paper fulfill the aim? Is it easy to structure it in terms of participant, intervention, comparatives, and outcome? So their aim was very clear: to assess outcomes of children with displaced supracondylar humeral fractures treated non-operatively in a rural Malawian district hospital where only non-operative treatment was available. Their population was all children with closed injury treated between January 1st, 2014 and December 31st, 2016. They excluded pathological fractures, congenital injuries, and those with open fractures. And their age range was those under 3 were excluded due to transfusional injuries, and those above 15 who couldn't be treated as an adult were also excluded. In terms of intervention, this included all those treated non-operatively, which included immobilization in a simple arm sling for 3 weeks, or overhead straight arm traction of the injured limb, which was mainly used to reduce swelling. And those that were Gartland's type 2 and type 3 were placed into a posterior slab plaster with the elbow in 90 to 100 degrees of flexion. Some type 2 or type 3, mainly the extension type ones, underwent closed manipulations under general anesthesia, but this was without any fluoroscopy, so without intraoperative imaging. And all patients who underwent manipulations were also immobilized in a posterior slab, again with the elbow in 90 to 100 degrees of flexion. And they were all immobilized for at least 3 weeks or until radiographic evidence of fracture union at the time of follow-up. As this was a retrospective case series, there was no comparison. All patients underwent some form of non-operative treatment. And how did they identify these patients? Well, these patients were identified from inpatient records. And in terms of outcomes, they looked at range of motion, the carrying angle. They used the Flynn criteria to assess cosmetic and functional outcome. They looked at pain, infection, the presence of neurovascular injury, myositis significans, amputation, and Volkmann's ischemic contracture. And they also interestingly looked at return to school, return to chores, and radiological union. And this was a retrospective cohort study. And all patients or their guardians gave informed consent, and this did pass through the Malawian Ethical Council. Would anybody like to comment on the PICO or anything that was unclear? I'll move on. So the background. So we know that trauma-related mortality and disability are increasing in low and middle-income countries. And Malawi certainly has a high incidence of trauma, of which a third tends to affect the pediatric population. And we also know that access to surgery is inadequate, and therefore most of these injuries are treated non-operatively. And although the literature supports the treatment with closed reduction percutaneous pinning, access to this isn't available in all hospitals, and certainly wasn't in this District General Hospital. And one of the quotes in the introduction is that few studies have actually examined the management and outcome of these injuries treated in low and middle income countries where surgery is often unavailable. And we know that these injuries are associated with considerable long-term disability and healthcare costs, and therefore assessing how they perform is really key. Anybody have any comments on the introduction or anything else from the paper so far?
Yeah, I thought they give really good context actually from the background and introduction. I thought it was nicely developed, and for someone who's non-orthopedic, gave me an idea of what the problem was. So I thought it was good, well written.
Yeah, and I agree. They did place it into the context and did explain the setup of healthcare in Malawi, which is really useful because it's a very similar setup to delivery of services in other low-middle income countries, where a lot of the care is actually delivered by, for example, orthopedic clinical officers or nursing staff in the rural setting. So it was really useful to see that. Thank you, Alva. So moving on to the method. So these patients were identified from the inpatient records, and all patients were referred to this district hospital for new elbow radiographs. As I mentioned before, the parents or guardians all provided informed consent, which is really key from an ethical point of view. And they contacted patients either by phone. Interestingly, they also said they made radio assessments, and it would be really helpful for Kieran at this point to tell us exactly what that entailed. And they also performed some assessments in the patient's own homes. In terms of functional assessments, I mentioned the Flynn criteria, and they scored patients for functional impairment cosmesis. Pain was scored from 0 to 10, and they looked at return to school and return to chores, and whether this was limited by the injury. And the clinical parameters they assessed are all marked there. And I'd really like to bring Kieran in to the discussion at this point to give us some more information as to how they went about contacting these patients.
Sure, thanks, Roa. I'm also here with one of the other authors, Laheen Amlani.
Oh, fantastic. Thank you, Laheen.
Yeah, so radio assessments, is that a direct quote from the paper? I hope it's not, because what we did radio announcements and then sometimes phone assessments. So basically what Elijah Mlinde, who's the first author of the paper, he's an orthopedic clinical officer from Nkota District Hospital. And really all credit goes to him for really performing a fantastic study here and doing all the follow-up assessments himself. What he did is he contacted the local radio stations in Nkota and asked them to broadcast messages saying, there's a research study being that's underway at Nkota District Hospital. We are looking to evaluate the outcomes of children who have had elbow fractures over the past 4 years. So please, if there are children with this injury, we will be visiting your village on this date. Please present yourself, to the chief or to the center of the village for evaluation. And so Elijah had a list of all these patients that he had treated in a computer that he kept, like a laptop that he kept on the wards in Nkota District Hospital. And that was really key. Without that laptop, none of this study would be possible because we had nothing more than just simple paper records for all of these patients. And all the other hospitals in Malawi, that's how this is done. But in Elijah's case, he kept electronic records that allowed us to go back and identify these patients that he'd taken care of. They had phone numbers listed, they had villages listed. And so when he went to the villages, he would go to the chief and go to the local, leadership in the villages and try to track down these patients. And the radio announcements basically helped him generate awareness so that people would actually go and follow up with him when he went to these towns. And he was riding around on a motorcycle with a small team, crossing rivers by foot to try to get to some of these really, really rural hospitals to perform this follow-up. And maybe now is not the moment to mention this. I guess you're on the methods slide. I think it's worthwhile mentioning that to perform follow-up evaluations in our setting here in the US and in your setting in the UK is very different than performing it in a place like Malawi. And so a lot of people in Malawi have this sort of silly saying that no news is good news, right? We don't hear from the patient, it must mean they're doing fine. But I think that that's wishful thinking. And I think that this study is evidence of that, right? A lot of these patients were gone. They were discharged. They weren't coming back for follow-up routinely. They were living in the communities. And we found, I'm sure you'll get to in a minute, that quite a number of them had some either cosmetic or functional limitation that was preventing them from returning to their normal lives. Many of them still had pain. Some of them hadn't returned to chores or school, right? So this can only be found out if you perform these follow-up assessments. And in this case, we actually had to have Elijah drive out there on a motorcycle and cross rivers by foot to do that. So it was a very arduous process. And I just wanted to make a comment. thank you for your lovely comments about our background introduction. Laheen was the primary person who wrote that, so I'm sure he's very proud to hear you give a compliment there. You know, the comment that was made that, you know, there are not a lot of papers out there that explore the functional and clinical outcomes from supracondylar humerus fracture. We know that because we did another study, a scoping review of the literature, where we tried to identify every single paper out there that does look at outcomes for these injuries, specifically from low and lower middle income countries. And we found that a lot of the papers that were published were either from like India or Pakistan, and they recapitulated the same kind of knowledge that we already have established in the high income country literature, which is that, you know, cross pinning is probably the same as 2 lateral pins, and 3 pins versus 2 pins has mechanical differences. You know, this is entirely meaningless for a population that has no access to surgery. The number of studies out there that talked about non-operative care were really, really minimal. So that was really critical. And then the second thing I wanted to mention is this study was the second study that Elijah performed using a similar technique, which we refined with a previous study, which notably is not being discussed in journal clubs because unfortunately we learned a lot of lessons in that one, right? So the first study that we did was examining clinical and functional outcomes of patients with femoral shaft fracture, children with femoral shaft fracture treated non-operatively. Actually, those children do quite well. They remodeled quite effectively. So we learned a lot of lessons from that study, learned how to do these radio announcements, how to do the follow-ups in the villages. He had a system in place, he had a team in place. We knew exactly where the funding would go and how he would spend that money in order to make this effective, and how he would actually perform those functional assessments when he was there on the floor. We went and did training and all that sort of thing. So I guess my point is that each study builds from another. And this study that you're seeing here, there's a lot of studies that came before it that led us to this point. So thank you. Sorry, long-winded answer.
No problem. That's really helpful to hear that. And that's absolutely key. I think follow-up is difficult in whatever setting, particularly so in this one. I've got 2 people with their hands up, so I'll go to Jonathan Jones. Would you want to come in?
Thanks very much, and good evening, Kieran and the team. Just well done on this paper, which is the 2 things I were going to say about it was that it's a fantastic number of patients that you've managed to capture data on. It's retrospective, and that's fine, but it's hugely descriptive, and so the extent of the data that you've got means that this is a fantastic, almost like a springboard into other research projects in the future. In terms of which I'm sure was the idea. And the other point I was going to mention was, you know, absolutely first-class effort in going out and actually retrieving the data and actually finding the patients in the community, because that's where the spade work is. And I guess the reason why it was obviously difficult to try and track some people down was that obviously because children do adapt amazingly, and particularly in a low-resource setting. So it may not seem a big problem, but when you actually assess their function, you realise that they are adapting hugely to a functionally suboptimal hand or upper limb. Anyway, that was my thoughts. But well done. Thank you very much for sharing it.
Thank you, Jonathan. And Alva?
Yeah, I just wanted to say how incredible the methodology is here, because if you can imagine any PROM studies that any of us have done in the US or the UK, and the level of response we get, and to envisage going around, and I think I read that some of the clinical assessments were performed in the patient's own homes. I just can't even imagine what it would be like to try and suggest that in our settings. And a 75% follow-up rate is absolutely incredible. I was really interested to hear that Elijah had kept a continuous record of all the patients treated, because I found almost absolutely nothing to criticize at all from this paper. My only question would have been, how do we know, that this retrospective cohort is a continuous one? And that's incredible. And what foresight he had to keep an electronic record of all these patients. And it certainly adds to the validity of the data. And I think just speaking about methods in general here, the outcome design was so carefully thought out, so robust, and very beautifully statistically analysed. So amazing methodology, and such an interesting insight into orthopedic care in Malawi.
Yeah,
thank you very much. The one caveat I would make to that is that you mentioned patient-reported outcome measures. I think that there's a real need to have clinically relevant and adapted patient-reported outcome measures for any setting. And in Malawi, there are a few outcome measures that have been adapted to Chichewa by one of my collaborators there, Linda Chikoto, who Jonathan Jones knows very well. He's a collaborator with her as well. So the EQ5D and the SMFA has been adapted into Chichewa. But things like the PROMIS score and other things that are, I think, better adapted to looking at pediatric outcomes, we do need to do more work on that to have that adapted. Like I'm sure you noticed in our case, we used return to chores, return to school, and pain. Return to chores, return to school, I mean, that's just a sort of yes or no thing. There's not a lot of nuance there. So that would be my one hope that, that we learned from this study, that if we could expand from here, it would be to have these really high quality patient-reported outcome measures that can then be used to translate into things like QALYs, that can be used for cost efficacy analyses, that sort of thing. That would be really transformative in a setting like Malawi, but it's really difficult with a language issue.
Yeah, and I absolutely second the need for individualized patient-reported outcome measures. So I thought it was really clever that you use return to school, return to chores, things that are actually relevant to that setting in Malawi rather than something which may not be relevant. So well done for identifying that. Any questions from any of the attendees at all at this stage, or any comments on the methodology? So I'll move on. So in terms of the statistical analysis, it was very clear and very thorough. So interestingly, you also looked at time. So you calculated the travel time to the hospital, and this was grouped into those either who took under 20 minutes or greater than 20 minutes. And then the other thing you looked at was both clinical and functional outcomes of only those patients who attended follow-up, of which we've already mentioned there were 75%. And then the analysis was undertaken using a standard modified Poisson regression, which is really absolutely appropriate in this case for looking at associations between the Gartland classification, which is essentially telling us about the severity of the injury and the outcomes, and also the association between the poor outcome and other covariates or other things that may be associated with a poor outcome. And I'll discuss those later on in the results.
Roa, can I just jump in quickly and just
absolutely
mention something about that transit time that you mentioned? So we wrote a paper a few years ago where we analyzed Linda Chikoto's preliminary results from her fracture registry, which was conducted at 2 central hospitals and 2 district hospitals in Malawi. And what we were looking at in that paper was risk factors for delayed presentation. And of course, one of the most obvious correlates with delayed presentation is how far away from the hospital you live. So what we used is this geospatial mapping methodology developed by a company called Rediviz that basically uses OpenStreetMaps data about the location of the roads and the type of roads, and then calculates an estimated transit time between 2 points on that map using the roads and the time that it would take to travel at certain speeds depending on the quality of the roads. So we use those systems to basically calculate estimated transit times for these patients. Now, I mentioned in the paper that the estimated transit times are not actually indicative of the transit times that the patients take to get to hospital, because obviously crossing rivers and using motorcycles like Elijah took to get to the homes is the same process they would have to do in reverse to get to the hospital. And obviously some of these patients took a long time to present. But what the estimated transit time gives us is a rough estimate of distance from hospital. So the threshold of 20 minutes was what we found to be statistically significant in that other study that represented whether patients were presenting delayed or not. So we really regard this like 20 minutes, which is really a rough estimate for time rather than for distance rather than time, as a threshold beyond which patients are considered to be living in very rural areas or living close enough to the hospital where they can get there in a timely manner and not present delayed. So that dichotomy there of 20 minutes was really determined by that previous paper that looked at delayed presentation.
Thank you for clarifying that. And that was going to be one of my questions later on, so that's really helpful. So I'm going to move on now onto the results, and I'm just aware of time here, so I'm going to try and skip over some of the main findings. So there were 182 patients in this cohort, and the mean age of 7, which is sort of similar to the standard suprachondral literature that's available. You had a relatively even split of males and females, And what most surprised me in terms of results was actually the number of complications, which fairly few. Interestingly, there was only one incidence of anterior intraosseous nerve palsy and only one of altered sensation in the distribution of the ulnar nerve. There was minimal incidence of valgus deformity and varus deformity, and that may be explained by one of the things that I'll discuss a little bit later on. And in 7 participants, there was evidence of radiographic malunion, of which most of these had a limit on their function. So when we looked at the patients, what I thought was interesting in the results was about the presentation of the total cohort. So these are all the patients, and also comparing it to those who had follow-up. And I thought this is an interesting way of doing it, so that I think, and I hope Kieran may correct me, is this is really looking at trying to assess whether there was any baseline differences between those patients who agreed to follow up and those perhaps who didn't agree to follow up in terms of the fracture classification or in terms of the treatment those patients underwent. So in terms of the clinical outcomes, we've already mentioned that the incidence of nerve palsy was very low, and it is incongruent with the reported literature. And that may be due to lack of documentation or perhaps inadequate documentation, as most of this was gathered from the patient's clinical records. And when you look at the Flynn functional outcomes, so we're looking at functional scoring and cosmetic scoring, you can see that the majority had excellent scores, particularly for function and cosmetic. But when you delve more deeply into return to school and return to chores, and remember we're using this as a surrogate marker as a surrogate prompt really, 85% returned without limitation, but 14% returned but were limited by their injury. And in terms of return to chores, which is really key in the low resource setting where a lot of these children may perhaps be helping family members, again, almost a quarter were limited by the injury. And when we looked at composite outcome, and they defined composite as any clinical complication, 55% had no clinical, but almost half, so 44%, had some form of poor outcome or clinical complication. And that's really quite a marked difference. And when we're looking here at relative risk, you can see that Gartland type 2 and Gartland type 3 in all forms of outcomes had increased risk of complications, increased risk of having a poor outcome or a less than excellent outcome for each marker. And sometimes it's relatively high, but you're looking here at return to school with limitation, it's almost 14 times more likely. So that is quite a marked difference. And in terms of their summary, really the main take-home messages were that Gartland type 2 and type 3 had an increased risk of clinical complications and functional impairment. The type 2s in particular had an increased risk of elbow stiffness, deformity, and functional limitation and pain. And when they looked at the covariate analysis, they identified that girls, older children, and children who live further away from the hospital or who presented late, those with medical comorbidities or early complications, those secondary to sporting injuries, and those who needed a longer in-hospital stay had an increased risk of a poorer outcome. And this is interesting because other studies in a similar setting have reported worse outcomes for girls. And we're not sure why this is, and it may be related to inequity in access to care. So it's certainly something to be looked at. And we know that delayed presentation does have an impact on outcome. And again, this is consistent with the previous literature. And I'd just like to open it up to the floor at this stage, see if anybody has any comments about the results or the discussion.
Kieran, this is an excellent paper. Sorry, am I supposed to raise my hand first?
No, absolutely, go ahead.
I know you won the prize with this one. Congratulations. A couple of comments. I mean, it is a retrospective study, and I completely accept the limitations of a retrospective study, and I think it's very, very well done despite these limitations. Couple of things. You mentioned there was very little in the literature about how do you treat supracondylar fracture. It's not my area of expertise. Is this a sort of a good way to treat these injuries? Is there a better way to treat it? Is there Jonathan can probably answer that. So,
you mean what is our standard in like in the US or whatever compared to this, or what is that what you're
in the US you probably pin it. I'm just asking if you're going to treat this closed, what does the literature say?
There are some, so maybe Jonathan knows more than I do. There are some papers out there that talk about various treatment methods. I mean, just to be clear, the way that the Malawians treat it is they do straight arm traction, right, for 3 days to 2 weeks, depending on how severe the injury is and how swollen the patient is. When the swelling is decreased, they take the patient to the operating room, anesthetize them, then perform a closed reduction without anesthesia. And, you know, it's typically just the flexion maneuver, which doesn't work great for the flexion deformities, obviously, but the gross alignment, like the varus valgus alignment of the limb is sort of done randomly, you know, based on like how clinically it looks, because they don't have fluoroscopy. And then they're put into a posterior slap splint and that's it. They're sent home. Yeah. So there are some papers out there that talk about doing electron skeletal traction, you know, doing closed reduction using X-ray and trying to hold it with casting. But I think that the idea is that these kids remodel enough, and so just putting them in the ballpark should be adequate. But I would hope that this study kind of demonstrates that maybe we could do better, especially for the Gartland type 3s.
Jonathan?
Oh. No, I was just going to pick up on the one thing is that with the complications is that there were very few infections, or if perhaps zero infections just from the blisters. So in terms of actually different types of treatment, if you are going to operate on patients, you're going to have a different set of complications, you know, with wire damage to nerves, infections, you know, and other things like that. But I was interested to see that even with the presumably some of these were open fractures, is that there's no significant infection rate even in those. Just confirming that, really.
No, there were no open fractures. All the open fractures should be referred. Yeah, these are all closed.
Yeah. Okay. And the other thing, in terms of operative treatment, you know, obviously, you know, the more severe fractures, would benefit from operative reduction, and but it has to be done well. Otherwise, you know, poor operative technique, increasing complications. So what's good is you have to almost like pick your complication, really. Anyway, you've got two good questions have come in from the group. So I don't know whether you want to deal with those now.
I've got one more question for you, Kieran. So again, I'm just looking at the methodology. Former post-operative photographs were made, and manipulations were repeated. I don't know whether you X-ray them again after you did the repeat manipulation. It wasn't mentioned, and were they finally happy with the position before you know, sort of calling it a day? So that I thought is quite an important point to clarify. And the final thing is, I mean, the average age of the children was about, what is it, 7? Is it 7? Yeah.
Yes, that's right. 7 was the mean age.
Yeah, I find it very difficult to examine for nerve complications in this group or younger. It's very difficult to find out whether they have actually any nerve symptoms, you know, sensation. So that to me is quite a major you know, point to clarify. Thank you.
Thank you for that. And I think that sort of harks on to some of the questions that are in the Q&A, which I'll move on to. So we've got a question here about outcomes, or a couple of questions about outcomes. I'll ask the first one, which is, can we consider any of the outcomes more important? I don't think you placed any sort of categorization in terms of the outcomes, but would you say that any were of more significance? And I'll put that to Kieran and Lahin.
Let me start with Wee's 2 questions. So I think that's a really important point. That
you didn't expect to come in tonight and get a critique like this, did you?
Oh, I was expecting it.
That's good. I hope you're enjoying it.
Oh, very much so, of course. I always love a good thrashing. Thank you very much. No, that's a very good point that you bring up. And, you know, it's probably an oversight on our part that we should have mentioned that the reductions were performed until the clinical officer was happy. That would be a better question for Elijah, unfortunately, who's not on the call. But I do believe that that was done, but I can't confirm that if the reduction was repeated, it was x-rayed and confirmed. But you know, the problem in Malawi is that for regular clinical care that's not being audited in a clinical study, for example, it's really challenging to standardize the system of care. A lot of our studies in Malawi have shown that it's not very standardized. So, you know, a lot of these things were also up to the clinician's discretion, right? They looked at the reduction, and if they didn't think it was appropriate, then they took it back for a repeat. How many of those were unacceptable in their reduction and were sort of left as is because the clinical officer was okay with it? I don't know the answer to that question. These are sort of the limitations of a retrospective study and a study performed in a limited resource context, where the standardization of care and the level of clinical expertise of the OCOs the orthopedic clinical officers can be highly variable. So I'm sorry I don't have a better answer for that, but you're absolutely right that that's a really critical point. Now, the 7 to 8 year old range for the children, that was when they were injured. So I agree, it's very difficult to examine a child's nerve, especially when they're screaming in pain because they have a broken elbow. Just to be clear though, a lot of these kids, they were being re-examined 4 years on average afterwards. So they were slightly older. You know, examining on an 11-year-old is a little easier than a 7-year-old. But yeah, I mean, maybe there were nerve injuries that were missed in the study, so we would expect that to be higher. Now, I think that part of the bias that we have here is that if a child had a really severe injury, perhaps they weren't going to Nkota Kota, they were going straight to Kamuzu Central. Or if they ended up with, you know, Volkmann's ischemic contracture, an amputation or something like that, maybe they weren't willing to follow up. So we do have a little bit of a follow-up bias here. Absolutely, I'm in agreement with that. But despite that, I think we still found that there were limitations in even the cohort that we have. So if anything, the bias was in the other direction, you know, but still we found a high number of complications. And the question that you had, Roa, about like what's the most important complication, that's a tough question to answer. I mean, because some of our complications, we're looking at really severe outcomes, right? Like Volkmann's, myositis ossificans, nerve palsies, things like that. But I think for us, the reason we stuck in return to chores and return to school is for a young population like this, that's really what we care about. The ability to return to a functional lifestyle in a community that relies heavily on, the agrarian economy. You know, something like 70 to 80%, I think, of Malawians, forgive me if I'm wrong with that number, rely on subsistence farming in some capacity to put food on the table. And children's education struggles as a result. Like many times children will go through primary education because it's funded by the government, but they will not go to secondary education. They will choose instead to work. And so I think the ability to return to school, get that valuable training that they're able to get during that time, that was really important for us. So we wanted to incorporate that finding. But we did have this composite outcome that sort of covered a lot of different areas. I hope that answers that question. I'm sorry, it's a tough one to answer.
No, thank you. That's really helpful. And there is another question in the chat here which says, they wondered about other factors and did you notice any age group difference? And I know that in the discussion there were some comments that in the bivariate analysis, older children had an increased risk of complications. And I just wondered if you'd like to comment as to why you think that might be the case.
Yeah, I mean, I think the older children just have less remodeling ability and less adaptive ability, right? I think that we and Jonathan would probably agree with me on that one. That's what we would expect.
Great, thank you. Now, are there any other questions from any of the attendees or any comments? I've got 2 participants with their hand up. So over to you, Jonathan.
I was just going to say, I mean, it might not be sort of teaching my grandmother to suck eggs, but in terms of assessing the injured hand, there seems to be the most sort of well tried and tested method to a little baby or a little young child is to put the hands up. That's the ulnar nerve, that's the radial nerve, and that's the median nerve. Because any child wants to do that, shoot them. Yeah, any child wants to do that, and any child wants to do that. It's okay. So if you've tested all those 3, radian, radial, median, and sorry, very simple, but just if anybody wants.
Yeah, that was exactly the training I gave Elijah when he went out to the community. It's what we teach all of our med students, Jonathan.
Yeah, no, it's really helpful to have some clinical tips for assessing these patients. Alva, have you got a question or a comment?
Yeah, kind of two questions, 2 comments, all in one. Looking at the discussion, I wanted to ask you if you made a conscious decision not to draw direct comparison of your functional outcomes to functional and clinical outcomes, really, to those that have been reported in the literature for pinning. Because my overall impression here is that everything about this paper has been very carefully planned and thought out. And I wondered if you had a reason why you didn't compare it to, say, the literature reported standard outcomes for these things.
Yeah, good question. I mean, I do think that, as we were saying, it may be a little bit like comparing apples to oranges, or maybe Jonathan was mentioning that earlier. Like, the complication rates from operating on children is going to be very different from the outcomes if you don't operate on them.
Yeah.
So that was one reason. I think we were also trying to highlight other papers that had focused specifically on non-operative treatment, since that seems to be the vast majority of these patients. Now, you know, I'm trying to remember, I do feel like we did mention that a lot of the outcomes, just in broad strokes, the outcomes from operative treatment of Garland 3s are typically better than what we saw in this paper. So that was the comparison that we did try to draw in terms of functional Flynn criteria. Yeah. The Flynn criteria have been like widely described for operative treatment of these injuries, and I do hope that in our paper we at least touched on that. We saw that these results in our paper were worse than what was published in literature. Forgive me if I'm misremembering that.
No, I think that is the case.
Yeah, alluded to, but not, I think, like completely spelled out with statistics and things like that. But absolutely,
yeah.
we did.
Yeah, we unfortunately didn't have a statistical comparison group. You know, like there is a small number. There are a small number of these patients that are operated on in like BayCure International Hospital, which is in Blantyre. But you know, that would be something that I would love to do in the future, to really do a prospective study where we look at this. But it's hard to establish equipoise, right? Mm-hmm. Because we kind of know from this paper that operating on these Garland type 3s, they would do better. I mean, Jonathan makes a very valid point that if you don't train, if you don't adequately train and equip the clinicians in Malawi to do surgery appropriately and properly, you know, you're going to have a really high complication rate. But on the other side, infections, malreductions, nerve injuries, things like that. So it's this very delicate balance that we have to find, our colleagues in Malawi have to find, where they have to, you know, recognize the limitations of non-operative care and have this aspiration for something better, recognizing that along the way there are many, many hurdles to overcome, right? So it's hard to design a study effectively to do that. We're struggling with that in so many of our studies.
And then, sorry, I just had a quick follow-up question. I'm so curious about sort of the framework about how you came together with this collaboration to design the paper, and also just, you know, what I'd just love to know, first of all, what was the Malawian presence from yourselves in the States? How often were you there, and how involved were you into the on-the-ground work of the study? And then I've sort of only just about delved into starting to write or read papers that work on regression. So I found this to be, you know, quite a lot to digest initially, but it's very well explained in your paper. And I think, you know, to report regression outcomes in a risk ratio in a problem like this seems so sensible, and it was very digestible and well done for beautifully represented tables and beautifully presented results. So yeah, I just would love to know, what was the setup?
Thank you very much. Again, Laheen here made all those tables, so, you know, well done, Laheen. So the collaboration that we have in Malawi began when I was doing my postdoctoral research fellowship. I was studying at the School of Public Health here at Harvard, and I would bounce between taking coursework here on things like regression analysis and going to Malawi, where we were building this sort of research collaboration. It began really as a collaboration with Linda Chikoto and Leonard Banza, 2 surgeons, one in Blantyre, one in Lilongwe, respectively. who had an interest in research and also looking at clinical outcomes. So the paper I mentioned earlier on delayed presentation for patients in Linda's fracture registry, that was the first project that Linda and I did together. We designed that project together. It was based on the results of her fracture registry. And we learned a lot of the techniques there, and that those first early papers we did helped us sort of create that trust and that relationship between us in the US and the team in Malawi, and helped us in the US understand the situation in Malawi enough that we could help our Malawian colleagues develop studies that I think were relevant to the clinical struggles that they experienced there trying to deliver orthopedic care to their population. So that's sort of how this began. During that time, I would be in Malawi for 1 to 2 months at a time, like every 2 months, basically. I would come here, take a class, I would fly back to Malawi, back and forth for the period of 2 years. Then I went back to my training as a resident, and during that time, my time there would be limited, but then folks like Laheen began to be involved in our group at the Harvard Global Orthopedics Collaborative. So Laheen currently is on a year out from his training, and he's spending the majority of that time in Malawi, helping do research projects, helping our clinical colleagues there set up projects and analyze the results, and do a lot of other capacity building activities, including education. So for this project, I was there when another student was setting up another project on ankle fracture that we had going on simultaneously. But I would just say that our presence in Malawi, I was there at the beginning of the study to train Elijah on the basic methods of performing clinical and functional outcomes, trying to track down all these patients and give him an idea of how to design a study. But all credit goes to Elijah for his exceptional performance in doing this study. He's the first author for a reason. He wrote this paper, he collected the data, he went into the community, met these patients, he treated these patients. And he's the one who's incorporating this through his lectures at courses like MOA, the Malawi Orthopedic Association, which is what Jonathan and I both collaborate in on an annual basis. He is evangelizing this data to teach other people in Malawi about the importance of outcomes research and also treating patients. So, a lot of credit goes to him. We could not do any of this if it wasn't for our colleagues in Malawi who are the ones really driving these projects.
Yeah, thank you for that. So I'm going to move on. I know it's a fantastic paper, Kieran, and it's really great that you're able to undertake such an important piece of work and collect so many outcomes in this population. There are, of course, limitations, and I won't dwell on these too much, but we know it's retrospective, and that is associated with the standard bias. I do feel that there is a selection bias, because although you had a 75% follow-up rate, it was only on those who chose to attend follow-up. It's a single center with a single clinician, which has some limitations in terms of generalizability of these results. And I do think that the lack of natural radiographs may have affected the ability to assess for sagittal plane deformity. I think the neurovascular injury incidence is very low, and that may be related to documentation or may be a true representation of the complications that you see in this setting. Maybe these are different types of injuries than what we see in a high resource setting, and maybe they're just not associated with neurovascular injury because they're different mechanisms, even though it's a similar patient age group. And we talked about, or in the discussion, you talk about the lack of initial radiographs and fracture classification, but I think you're broadly able to classify them using a commonly used classification system, which is the Gartner, which the majority of us use for these injuries. So I think that was all very clear. But I think what is important is that despite being very limited, despite these limitations, it does demonstrate that most of these patients are receiving unacceptable outcomes because they're being treated neuroperatively in a low resource setting, and without improving overall access to operative fixation, then we will continue to achieve these poor results. I think it's really important that we improve pediatric orthopedic surgical capacity, not just in Malawi, but in other similar settings. And that needs to be done very carefully, guided by an educational program that ensures that these procedures are done appropriately with standardization and training of all those who are providing care. And that can only be done through, of course, investment and improving the resources that are available. So thank you very much to Kieran, and thank you for to Laheen as well for all your efforts on this fantastic paper.
Thanks, Roa. Can I just make point about the no lateral radiographs to assess the sagittal plane deformity. That was like a huge, like I was pulling my hair out when we discovered that that was an issue. As we were analyzing the data, as all you guys know, we noticed that one of the big limitations was range of motion. And of course, that's probably related to sagittal plane deformity. So I asked Elijah, hey, do we have those radiographs that you took on all those patients? Like all the patients with outcomes, we said, come back and send them to Kota Kota District Hospital so we can get radiographs. We had money in the budget for them to take the transit all the way back to the hospital to get those radiographs. But it turns out that lateral radiographs are not a standard of care in Malawian district hospitals. Like when you ask for radiographs of the elbow, they take a single shot. And so we were able to get Bowman angles, but I didn't know that. I didn't think that that would be the case, you know? And so when we designed the study, when we did the training, when we implemented this whole protocol, it didn't even occur to me that that would be an issue. And then here we are at the end being like, oh, let's just go look at the lateral x-rays. They don't exist. They have never been taken. Huge limitation, you know? So the point I would make here is you don't know what the struggles are going to be until you start actually doing research in limited resource settings. And you will always have struggles. You will always have challenges, and you just have to dive right in and discover them as you go, you know? Unfortunately, this was a big limitation for our study, but we learned the lesson and now we'll apply for future studies for sure.
Thank you very much for that, Kieran, and thank you to everybody for joining us this evening. I'm just going to open it up for any more questions or comments about this paper.
I was saying one of the lasting pictures that I remember from visiting Lilongwe is that quite often the children were actually two to a bed. So there'll be two children with supracondylar fractures, one at one end and one at the other, which is quite a challenge. But depending on left and right and so on. But no, I think it's been a very interesting paper to go through, and it's certainly, in fact, you know, it's whet the appetite for helping those collaborative studies going on in low resource settings to try and get some more of this data, because this is really valuable for funding for healthcare in the future. I mean, even getting standardized X-rays, you know, that's a start, isn't it? Thank you very much.
Yeah, absolutely. And I think it also sets the foundation for some work looking at a core outcome set in a low resource setting, one for the pediatric population and one for the adult population in trauma. I think that's really key. And that's something that we can certainly all sort of have in the back of our minds, and perhaps a consensus meeting is in line for the near future. So thank you, everybody. I'm just going to open it up to all our panelists. Alva, have you got any comments?
Just so pleased to have such an amazing panel and also audience contribution. Very well chosen paper, Roa. It's been really fascinating, even from an orthopedic absolute novice, to listen to and interpret and discuss. And what a privilege it's been to have the study authors here with us on this call. I would love this to be a continuing theme for these joint journal clubs. So well done you, and well done everybody for your contributions.
Yeah, I think it's fantastic to have the authors with us. Any final comments from Wee or Jonathan?
Well, you know what I feel about your paper, Kieran. You know what the BSSH felt about your paper. I hope you got your money. Yeah, well done. Thank you. Well, thank you, Roa.
Thank you to everybody that's joined us, and it's been a wonderful evening. Thank you for asking really interesting questions. Thank you for engaging in the discussion, and thanks to everybody for giving up their time to join us this evening. I should really end. We did have some slides on study design, and I think we just want to be respectful of everybody's time. It's already coming up to 8:30 now, or perhaps a different time where you are. But do join us for the next journal club in February, and we will aim to include these study authors for each future paper. So thank you very much for joining, and the session will be recorded and will be available on the BSSH YouTube. It will also be available on the BSSH and the BFIRST website. And do feel free to get in touch with us via any of these methods. And thank you to everybody for giving up their time this evening. Thank you.
Thank you. Bye.
Bye now.
Bye now. Merry Christmas.
Bye, everybody.
And Merry Christmas indeed. Thank you very much.